Are we online?
Yes, Dr. Obua, good evening.
Testing. You're living at the same time.
For everyone who has joined, you're very welcome. We'll just give people about 3 to 5 minutes, and then we can start. Talk to you after, okay? Okay. I guess we shall start. Thank everyone. You're all very welcome to this webinar. Thank you for taking. Sorry, let me try and keep my area quiet. Have a bit of background noise, people from school. I think it's better now. I'm very, very sorry about the noise. Good evening, everyone. You're all very welcome. to this webinar. We're just going to discuss and find out more about the drug abuse by the health worker. And before we start, we would like to thank our sponsors, Troika. We would like to thank our sponsors, Troika, for sponsoring this webinar. They're a multinational company. They're based in India, and we've used most of their products, like bupichoy, ketamine, or ketamax, tricurium, dynapa, and many others. And most of their drugs, as we know, end with troy. So this webinar, we'll have Miss Grace to come and tell us a little more about their products before we have our guest speaker for the evening to come and discuss what we planned to talk about. So Miss Grace, the floor is yours.
Yes, I welcome everyone to this webinar. Once again, my name is Grace Niwaha from Troika Pharma, and I welcome everyone on this webinar. As a Troika, we are really an innovative company, and our philosophy is we imagine and innovate. And I've been cherishing the trust of anesthetic drugs or in the anesthesia fraternity for more than 30 years. So Troika is a company that has been there. It's not a new company. And this evening, I would like to introduce to you some of our products, which some of you have already had a hands-on, have seen or have used. One of it, first of all, like as a Troika, as I told you, we are thinking different in spreading the light across the globe. And we stand on three things, that is understanding patient need, and of course making quality products. So as a Troika, we manufacture products on our own. We don't have a third party or where we manufacture drugs and we have someone who sells for us. No, we have our manufacturing plants, and we have three, which are found in India. Basically, Troika is an Indian-based company, and each manufacturing plant is equipped with world-class manufacturing facilities. As you've seen, we have two in Gujarati, and another one is at Rakandi. And with our companies, Troika, we are situated in more than 70 countries across the globe. And we have marketing offices in each country, as you sing. So allow me to introduce to you Bupitroy Heavy from Troika Pharma, a quality brand of bupivacaine. That is bupivacaine hydrochloride, 5 milligram, then with dextrose, 80% or 80 milligram per mil. And ours, it comes in 4 mils, and it is a preservative free. Basically, that is for spinal anaesthesia. So whenever you're doing your spinals, you should consider to have Bupitroy Heavy, a quality brand of bupivacaine from Troika. What makes our Bupitroy Heavy a unique brand from others is that in the process of manufacturing Bupitroy Heavy, sterilization. Actually, geosterilization is double sterilization. We do sterilization of the ampule after manufacturing. Then also we do ethosterilisation, that is ethylene oxide sterilization of the blister pack. So after packing, we do also sterilization. So we are very well assured that this product is of good quality, and also we emphasize or ensure on the safety of the drug to prevent, of course, the contamination. And another thing is that our perpetual heavy, it comes with a 1-point cut, whereby in breaking is much easier. And of course, it reduces the chances of contamination, like when you're breaking and the ampule gets those small particles. So we emphasize that our product is of a good quality. That's what, the uniqueness with our perpetual heavy. Good quality with dual sterilization and easy to break with the 1-point cut. Then the second product is that the second product is Troipofo. That is our brand of Propofo. That is 1% weight per volume, or 10 milligram, and comes as 20 mils. The uniqueness with our Troipofo brand with other Propofo on the market is that we, in mixing or in the process of manufacturing, we use nano-immersion technology. This technology basically talks on the oil water solubilization. So this nano-immersion technology, it gives uniform or nanomized uniform globules of propofol, hence making the molecule less painful on injection. And of course, our Troipofol brand has a better efficacy comparing to other brands of propofol. And of course, less painful and less post-operative nausea and vomiting. Yeah, so as I told you, everything with the Troika in manufacturing, they use totally hands-free. It is, everything is done with machines or equipments. So this is one of the state of the art of our machines or our plants where they manufacture parenteral injections, especially like the Troipofol. As you're seeing from the video, that's how we do manufacture our Troipofol. Yeah, from, of course, this video, the point I can tell you that our products, they are manufactured with utmost care. We emphasize that everything is manufactured very well. So we emphasize on safety of the drug to your patient. So I assure you that you can use our products because of the good quality. And with our Troipofol, on addition, we get the raw material, the active pharmaceutical ingredient is from Italy. That's where we get the raw material for Propofol. Then also it's glass vial, it's from Germany. Then the topper, the blue topper you saw, it is from France. So however much we manufacture our products from India, most of our drugs, the raw materials or the ingredients, we always get them from those UK countries. Then maybe I can say lastly, our brand of sevoflurane, that is Sevotroy. Sevotroy comes still as a 250 mils, And of course, as you know, the advantages of sevoflurane, it has a sweet smell. Of course, it is more hemodynamic stable, especially for the pediatric surgeries, then in neurosurgeries. And another thing, our Sevotroy bottle, it is very compatible with ECSA or powered fill vaporizers. So wherever you find such a vaporizer and ECSA, there is no need of an adapter or a filler. Unlike the key fill vaporizers, where they need an adapter, but our Sevotroy bottle is very well compatible with easy fill vaporizers, open or is open and fill vaporizers. And of course, it has another advantage of water. It has optimum water content in that it is more safer for the vaporizer not getting like corrosions. It has an optimum water content. Actually, it is around 700 ppm. I know you're good at doing research. You can also go back and read more about it. But on protecting your vaporizer, it is very well safe because of the optimum water content in it. And another advantage is that in case you have a key filler vaporizer, our Sevotroy bottle still comes with a separate filler or a separate adapter. So still we do provide whoever buys our brand. But our humble request is continue recommending our products in case you find a hospital is having a vaporizer that uses Sevo, you kindly call us. My number, my contact is very visible. You can note it down and support our products. Also have Dynapa injection, that is 1 ml, diclofenac IV, also available, especially those who are in government hospitals, those who are in private. It's available in NMS and also GMS. Thank you. Thank you for listening to me. I wish you all the best.
Thank you very much, Grace, and the team from Troika, for reassuring us about how our medication is processed or how you make the medication that you supply to us. A lot of other people have joined. Thank you very much for taking off time to come on. So my name is Rachel. I'll just be coordinating the events of evening. So before we go on to the main course for the evening, let's utilize the chat section and the Q&A section for any questions we have either towards Troika or to our guest speaker for the evening. As I was reading, I found out that about 7 years ago, that's in 2013, 7 in 10 medical workers had an addiction that was prescribed at the hospital. So we're about 32 here. So if we grouped us into groups of 10, 7 of us would report an abuse of a certain medication. And one of the risk factors is usually the fact that we have access, we've read so much, we know how these drugs work. And I bet Dr. Obua will be telling us more about which people are at risk of doing that, and we might start to report ourselves. Before he comes on, I'll just read for us a quote I found from a resident who was a former drug addict. This resident was a resident in the Department of Neurosurgery, somewhere in the world on earth. And he said that sometimes he would be standing at the door of an operating room and he would feel uncomfortable and it would look like he had a flu. So what he did, he would excuse himself and run to the bathroom and take 10 Tylenols of Panadol as well as codeine, and he would be normal in 5 to 10 minutes. I don't know how many of us are like that, but Dr. Obua will tell us more about that. So this evening, we'll have Dr. Obua talk to us more about that. He's a consultant anesthesiologist, and he works with the Department of Anesthesia and Critical Care at Mercury University. So let's make welcome Dr. Obua. Dr. Obua, the screen there.
Thank you very much, Rachel. Kindly allow me to just share my screen. I hope my screen is visible. I think it's still afternoon. Good afternoon, everybody. I'm called Daniel Obua. I'm going to be the lead speaker for this evening's topic, that is drug abuse and medical worker. I'm a member of the Association of Anesthesiologists. And for all intents and purposes, I would like to declare some of these, make some declarations before we proceed. I was introduced, I'm a lecturer at the School of Medicine, Department of Anesthetics, Mercury University College of Health Sciences. I'm also affiliated to the Association of Anesthesiologists. Currently, I'm serving as the Vice President. I've held other positions within for a long time. I'm also a member of the Intensive Care Society of Uganda. It's a sister association to AAU. I also sit on the board of National Drug Authority, but it has nothing to do with this talk. I'm also a member of Uganda Medical Association, and I've received some tokens from the two pharmaceutical companies listed. However, they had nothing to, whatever it is that I picked from them has nothing to do with this talk, except for the sponsorship from Troika. None of the views I'm about to express has been influenced by any of those honorariums that I've received from them. And the last declaration is that I'm an anesthesiologist, an intensive care physician. I'm not an expert on substance abuse. I'm just sharing some literature that I hope will allow us to spark a discussion and see how to move on from here. Because as you will realize that health workers have lots of issues. And unlike the police and other people who have specific offices where they go to, where someone actually gets to treat them in case they have challenges, health workers generally do not have functional occupational offices, at least not in this country. So they get to struggle on their own. I'm hoping that by the end of this discussion, we are going to be able to talk further and see how to move on. So you must be wondering why drug abuse? The whole word sounds not very nice, but it happens and it's probably not about to stop. Every other year, it seems to be getting worse. So when we talk about drug abuse, we are talking about a lot of substances. The commonest one is actually alcohol. Someone was asking me, are you going to talk about alcohol? I'd be like, yes, that is where most of the problems actually come from. But there are other things. So so we shall be using the word drug abuse, substance abuse, and alcohol abuse, or alcohol and other drugs, that is the AOD, that we shall be using them interchangeably. But maybe before I go on, and it's fine, I think I'll introduce some of the common terms later. But just to kick in, the WHO estimates that about 2 billion people out of the 7 to 8 billion in the world actually consume alcohol. And out of those, about 80 million of them have a diagnosable alcohol use disorder. I'm going to talk about this particular disorder later. Doctors and other health workers, laboratory technicians, nurses are at particularly higher risk of alcoholism and substance abuse. This was highlighted by Harris and Chick in 1994, where they conducted a retrospective review in Scotland, and they found out that in over 20 years, a space of about 20 years, there were lots and lots of professionals who are having challenges with these, and especially those who were above the age of 45. Another study showed the prevalence of about 15%, which is more than the average prevalence of alcohol and other drug dependence or abuse. In Uganda, I'm sure some of you came across these statistics, that Uganda's per capita consumption of alcohol is about 23.7 liters in 2016. And the prevalence was about 26.8%. And nearly 10% of the health workers, 10% of Ugandans had some form of alcohol use disorder. This was a study which was conducted by some of our colleagues at Ministry of Health, headed by Obua. Another study in 2008 identified nurses and doctors to be among the people who are most affected by addiction. This is another important piece of information that I thought I would bring forward, is that doctors don't just come from anywhere. Nurses don't come from anywhere. They come from their training institutions. So I thought I would throw in a little bit of this statistic just to give you an highlight of where the problem actually starts. So substance abuse has been proven to start from the medical schools and way before that. And we're looking at abuse rates of about 32 up to about 80%. Some studies found up to 90% of medical students were actually using some form of substance. The 90% was for alcohol itself. In 2014, Dodi in India, Mumbai, also found a rate of about 23%. Now, these 23% are the ones who are admitted to using substance on a daily basis. So you can imagine how big the problem is. Not the ones who are doing it once a month or once a week. This is a daily rate. So that is 23%. It is a lot. So now that we're going to go and talk about other things, I think we need to have some common terms that I'll be using for the purposes of this discussion. These are standard definitions. It's not an operational one, so you expect it to apply everywhere. So we have the substance use disorders, which is generally involves behavioral patterns in which people continue to use a substance despite having problems caused by its use. So you use something, you get problems from it, but you continue to use it. And most times you find that it is very difficult for them to actually stop once they start using it. You may find other definitions which are a little bit varied, but the common concepts are the same. Then you have alcohol use disorder, which is also a medical condition where the person using it has an impaired ability to stop or to control the use of alcohol, despite adverse social, occupational, and health consequences. They just don't care. Yes, it's causing me problems A, B, C, D, but I just thought I just have to continue with it. And based on this, there are lots and lots of alcoholics around, and that includes this room. I'm probably more of an expert in using the alcohol than talking about it. And then the other word that I wanted to bring up is the word abuse. Abuse generally means using something for the wrong purpose, for the wrong reason, or for the wrong intention. You can also call it misuse. Now that we conversant with some of the common terms we shall use, there are others which I think I will define as we move on. Now you must be asking yourself, why are we concerned about the health worker? Why are we concerned about the medical workers? What is so special about them? Everybody has a drug issue, but why are we concerned about this particular group? Like I said before, this particular group has been found to be at a higher risk of developing drug dependence, drug misuse, and also addiction. Mind you, there's a very fine line between addiction and dependence, but for the purposes of this particular talk, since the line is very thin, I think we should look at them as something which is, we can look at them as equivalent. But I'm sure our friends in mental health will fiercely disagree. Like I said, I'm not a mental health expert. So just keep that at the back of your mind. So why the concern about health workers? Apart from them being vulnerable, they also look after people who are vulnerable, who are at risk of having adverse health effects. Those people are called patients. So I wouldn't imagine being a patient and then my doctor comes in and they are under the influence of drugs. That would be very, very depressing. But it does happen. Like I said, it happens. It's probably not about to stop. The only way we can deal with it is to try and help the ones who are affected so that they can drop the habit and treat their patients professionally. Nurses have also been flagged to be at risk. And as you can imagine, nurses do most of the work in the hospital. Some of them prescribe drugs. Well, at least not in this country, but in other places, there are those who prescribe drugs. They administer drugs to patients. They administer fluids. They help during surgery. They feed patients. They bathe patients. They move patients around the hospital. So this particular cadre do a lot more work than their other colleagues, the doctors, do. So the mere fact that they have been coded for high risk for practice impairment should be of serious concern to anybody who is in this industry, either as a patient or someone who runs it. That includes the human resource people and the administrators. The health worker who is having substance abuse disorder is a danger to their colleagues. They are also a danger to themselves. There is a statistic that shows that the deaths from drug misuse globally and among health workers actually surpasses deaths from things like homicide and suicide. So people overdose on drugs so often and they actually die. You may find you've lost more health workers to drug overdose compared to, let's say, somebody shooting them on the street and them dying, or being mugged, or whatever it is, or being beaten to death. So that means this is a serious problem, and that is why there's a lot of concern about it. Loss of productivity and loss of job is another problem that is there. Loss of productivity. The example that was given is just one of the very many that actually have been published. People have been interviewed and they say, you know, the guys are always sleeping. Some of them are always sleeping and they are never up to the task. The chatting is incomplete. So it's a problem for someone who is supposed to be providing a service. They are not productive at all. They're just looking around to fix their drug problems. See how can I score maybe 10 codeine tablets, or how can I talk to so-and-so to get me some oxycodone, things like that. And then at a certain point, of course, they get to lose the job, which is a problem. And this particular problem gets worse because globally, there's a general shortage of health workers. In anesthetics, it's even worse. So imagine you losing someone being put on the sidelines, either to go to rehab or because they are completely non-productive. The person is always high. It strains the rest of the people who are supposed to be doing the work. And because some of the people are really critical, like imagine your anesthesiologist gets high and can no longer conduct his anesthetic. That means if he's the only person scheduled for that day, it means the surgery has to be canceled. So the drug problem goes beyond the person who is using it. Some of the health workers have assaulted family members. Others have committed murder just because they're under the influence of drugs and alcohol. Others have gotten drunk and knocked people on the street while they're trying to drive back home. So the problem is big, and that is why there is a huge concern about substance abuse. Now, you may be asking yourself, what makes the medical worker so special that they get to have all these problems? I'm going to tell you a few reasons why they're a little bit special, or why they are more at risk of becoming drug addicts and substance abusers. The first thing is, you have the community, and health workers don't just come from it. They come from they're like everybody else. They come from the community, and the community already has its own drug problem. But by virtue of them being health workers, they have access to certain drugs that the people out there would kill for. So you can imagine what they are bound to do with it. If they're already using something, let's say alcohol at home and in the community, imagine they come and they finally discover that, oh, it's actually not as hard for me to obtain, let's say, get several tablets of codeine, get my hands on morphine, get my hands on things like ketamine. It becomes a problem. So the access, actually studies show that the easier it is for them to access these particular substances, the rates of substance abuse or addiction proportionally goes up. In some instances, it goes up by just the mere fact that they're able to find these, the substance abuse goes up like by up to 6%, which is definitely a problem. So apart from the access, the work environment alone is also another problem. Is that the work is so stressful, especially in areas where, like I said, health workers are not enough. So it means in any part of the world, they are going to be overwhelmed by all the patients they have to see. Most of the patients you're seeing, it's not like you agreed that they should come with a particular condition. Some of them are very sick all of a sudden and they're at risk of dying. So it is a very stressful work environment, and there is not much support that is offered, at least not in our setting. And that's a very big problem. So because of this, you find out health workers have a burnout rate. I think the last survey they conducted was about 44% burnout compared to about 28% in the general population. So that should show you that these people have a very stressful work environment. And if they are not good at coping with that stress, then they end up doing things like drugs and alcohol to try and relieve that stress. Of course, eventually that is very counterproductive. The other issue is access to prescription. A study showed that more than half of the doctors who were on any form of painkiller had actually prescribed it to themselves. So if you self-prescribe a drug, it means you as a potential abuser, you do not have the means to objectively monitor it. Let's say you get yourself a dose of fentanyl. When do you stop? At what point do you say, I think this particular drug is becoming a problem? But if someone else gave it to you and you go back and say, I think I need more of this, they're not just going to give it to you. You will have to give them a very valid reason why you need it. And this is a problem. The other issue is the issue of being highly functional abusers. For some reason, health workers are very good at what they do, even when it comes to abusing the drugs and other substances that they have access to. Is that because they're highly functional, what this basically means is that they can abuse these drugs and it will be very difficult to tell that this person is actually under the influence of drugs or other illegal substances. Some of the substances are not exactly illegal, but the way it's used in the wrong way, it's used poorly, and it is overused, and that is where the problem is. That is where the abuse aspects of it comes in. So these people can get high and they can hide or mask all these features that you'll be looking for so well that you may not know. So it means cumulatively, you'll keep having more and more and be having less of them actually being treated. So that is what also makes them special. The other issue is issue of exposure. Imagine you get exposed, you go to work to you go to do your work, help other people get better, surgeries and the rest of it. And then you're getting exposed to small quantities of some of these highly addictive chemicals on every single day. So eventually you get hooked on it. And sometimes this thing comes as a joke. I remember one of my colleagues decided to give himself some anesthetics. I think it was Allothane. And we laughed it off and said, this guy is just crazy. Well, he anesthetized himself and fell off the table eventually. And we thought it was a joke, but later on, when we looked retrospectively, that was actually a problem because the problem eventually showed up. And we're all beating ourselves and say, how did we not see this coming? So exposure to certain things, you are giving certain gases to some patients, and then you smell it and be like, oh, this thing doesn't smell that bad. This is actually good. And before you know it, you are beginning to experiment and try to work some of these things up. Now, you've heard me talk about substance abuse, drug abuse, whatever it is that I mentioned. Now, I just want to see what exactly are these substances that we're talking about. Like I said, alcohol is probably top of the range. It's the one that every other person, whether they are health workers or not, is actually on. I did share the findings of a study conducted by, it was one of the largest surveys that was conducted in Uganda by Obua, and they found out that a lot of people were using alcohol. And alarmingly high, very high numbers were categorized as medium to serious users or to severe users, like high-end users. And those were, most of them were males. Western Uganda featured very nicely there. Northern Uganda, people thought it was because of the 3 decades of war. Busoga did very well. I think their levels were quite low. And the central region had, had very many people who were consuming alcohol. Tobacco is the other. Tobacco, these figures I'm giving you is from a Kenyan study. I couldn't find something from Uganda. This was the nearest I could get. That these statistics were for substance abuse among Kenyan health workers. So alcohol, this was Mokaya in 2016, was at 35.8%. Tobacco was at 23.5%, and God, the Kenyans can smoke. And then kat or mira or mairungi, these are amphetamine-like substances. They are leaves that you usually see most of the Somalis. They for some reason, they like it a lot. They are always chewing it. And in some parts of the country, if you go down to Arua Park or you go to Arua itself, West Nile, they chew a lot of these leaves. It usually goes with big G. If you see someone with a big G, they're probably chewing this thing somewhere along the way. They found this at about 6.4%. And I was once told by one of my sisters that if you decided to arrest people in Arua for chewing these leaves, you will not have enough space in jail. So at some point, you just let them be. You let them chew their things and they move on. Otherwise, if you start prosecuting them, the government may run out of money. So you can imagine what will probably be more than 6.4 with the people from the Horn of Africa around, and then other areas like West Nile. I think we probably should find out how much of these people should use. People are actually using. The other substance is cannabis. Other people call it Mary Jane, others call it weed, others call it the reefer, and other sedatives. Now, the weed is something interesting. In other parts of the world, people are legalizing its use every other day. In Uganda, it's still a bit of there are still a bit of caveats to this. But the Kenyan health workers, about 9.3% of them were actually using weed. And if you go through the medical school or you ask any single doctor or nurse, they'll tell you they know at least a few people who are doctors, nurses, lab technicians, all cadres in the radiologists radiographers who actually smoke weed. And that includes me. I know a lot of people. If one day I decide to snitch, it's going to be a mess. And I'm sure each of you has a very long list. The other is cocaine. Cocaine is expensive, but at some point also, like I was mentioning earlier, about 2015, 2016, they found that there were more people dying from substance abuse than the cocaine the epidemics of the 1980s. So you can imagine there are lots of substances killing people more than cocaine did in the 80s, just among the general population, health workers. So it's still a big problem. But I don't know how the Kenyans do it, 8.8%. Wow, the guys are even rivaling weed, and yet the weed is a lot cheaper and easier to get. I don't know where we are as Ugandans. We have hallucinogens, things like LSD, or other people call it acid on the street. They found about 5.4% of people were using it. Opioids, now these are prescription opioids. There were about 3.9% of health workers using it. And then other group of things that are generally inhaled, things that you breathe in, were lumped up, and they were about 3.4%. Then there's the issue of ketamine, or what is called speed K on the street. I did not find specific statistics, but I know this has been a serious problem around the Mbarara area, not precisely with the health workers, but with the secondary school kids. This is what they are buying because there's easy access. They are buying and using it to spike their drinks while they go to dance in the clubs. In Kenya, it's a very common recreational drug in Nairobi, especially Nairobi, and some parts of Mombasa, where they basically just bake it in a spoon, the way you've seen other people lighting it up in a spoon and crystallizing it, and then eventually either sniffing it or injecting it. But I think the Kenyan version, they're mostly breathing it in. So, like I said earlier, you may ask yourself, did the problem appear from the blue or it came from somewhere? I already talked a lot about this. The only thing that I want to bring up at this point is that the medical schools are a hotbed for people learning how to use drugs and other substances. A systematic review of 2018, a few years ago, actually showed a pool prevalence of about 35%. Now, this was not just medical students. These were medical students and house officers, basically residents. They found a pool prevalence of about 35%, with about 8.8% of the medical students still actively using it at the time of the time that review was actually released. Alcohol, like I said earlier, is about 90%. Ketamine, I'm not sure. We probably need to conduct a study, because everywhere you go in the theaters, you find people have left them just there for someone who is interested in to come and take. And they don't control this as much as they should be. And I think this is partly the reason why they wanted to add it to the to a list of highly controlled substances. But I think the anesthetic societies around the world have been up in arms, because in most parts of the world, this is the only anesthetic that is actually available. But should we turn a blind eye and look the other side and forget that people are actually misusing it? Maybe we need to find out who is using it and how much are they giving, and is there a disparity between what they say they're giving and what the patient is actually getting? Food for thought. Now, we're going to say who is at risk. Yes, I know you may say I'm a little bit biased, but a study actually showed that anesthesiologists were highly at risk. That included the surgeons as well, and general practitioners. I don't know why general practitioners were at risk, but for the other two, they say their work environment, they say, is more than average stressful. So they thought it predisposed them to be at high risk. Internists, internal medicine specialists, in one of the studies quoted about 31% of them. Imagine that's like 1 in 3 So in that particular locality, 1 in 3 internists was on some sort of substance. That is very alarming, but it's something that we cannot ignore. The others were nurses. Nurses are not, nurses tend to stand out from this group because nurses are actually at the bottom, not by mistake, because they seem to be the people who are the least affected when it comes to substance use or dependence. They found out that the rate of drug use or abuse among nurses and nursing students were close to what is actually in the general population. But where they were affected, it's mainly the older male nurses who were more affected compared to the female ones. Just like in the general population, the males are always having issues. They like to experiment with a lot of things, even when it comes to weed and alcohol abuse and anything else. And then it needs to be noted that most of the nurses are actually females. So the drug issue with the nurses is not as much as it is with the doctors. I talked about some of this earlier, so I'm probably not going to dwell on it again, but these are some of the factors. So when I talk about risk factors, I'm looking at what is it about the medical worker that makes them more, have a high propensity to drug abuse and addiction. So the first 3 I've already talked about, actually the first 4, but there's something called pharmaceutical invincibility, where doctors or health workers in general think, because we know these drugs in and out, we know how they work, there's no way I can get addicted to this. And I think the moderator said something about this. I was happy that she was able to mention it. So they feel they cannot be touched by these drugs. I can use this with impunity and nothing is going to happen to me. After all, I know these drugs, I know how they work. I don't think it will be a problem. So because of this particular complex, a lot of them actually end up getting hooked up on these drugs. And then it's also been found out that the health workers have a lot of physical pain. So eventually they're going to try and treat it. When was the last time you went to the hospital and found doctors just sitting there doing nothing, or the nurses or the lab people are just there sitting? The way the rest of the people sit, other professionals sit in their offices and do their things. Accountants will sit the whole day, do their work. But the doctors they're always doing something. Every time someone says, whoa, you're gaining weight, I'll be like, oh, maybe that's because I'm no longer seeing patients actively. Because I used to run around the hospital. Oh, there's a cardiac arrest here. Oh, there's something going on in theater. Oh, the ICU needs you. Go down to the emergency room. And it's always like that. So that high stress environment, and then you having to be up on your feet the entire time, you're lifting patients from their stretchers to the operating room bed, then you're picking them, putting them back on their beds, pushing them across the hospital corridors to go to radiology, go to the wards. So you're basically doing a lot of work. You're doing a lot of manual labor. And because of that, they found out that a lot of health workers actually do have physical pain. And when they start treating this pain, when they start prescribing themselves medicines for this physical pain, or start getting help for this pain, including self-prescriptions, they start having problems. So these are some of the things that puts them at risk. The male gender, the male fellow is always trying to do something, trying to experiment with something. And they're always starting from weed, like I said before, to other drugs that you can think of. They are usually, if you to group them into males and females, it's like we just have a death wish. We want to do all the stupid things in this world, and that I think we shall still continue. They also found out that the health worker who has had medium to high-end alcohol use before is also at risk of turning into a serious substance abuser. The other finding that research came up with was that what they discovered is that the people who socialize with people who socialize with other drug abusers eventually become drug abusers. Look at alcohol. If you drink alcohol, turn around, start thinking and count all the friends you have who do not drink alcohol. the number is going to be miserable. It's going to be so low. Same thing with smoking. Same thing with people who smoke weed. They always tend to hang together. So they move in packs. So they also found out if you socialize with people who abuse substances or who are dependent on some substances, you're also at risk of carrying on with the habit. The other thing that they found were significant when they conducted studies was that what they call being in a situation. Imagine you're having your issues, you're in this serious situation of yours, and then someone offers alcohol and other drugs to you. You're most likely going to be taking, you most likely will not be able to say no. You'll get tempted and you'll eventually start using them. So being in a situation, medical workers are always in the situation, they're always in that zone. So when someone offers them something that can sort them out, they know what the dangers are, but they'll still go ahead and use it anyway. Other findings from studies. Early fast access to tobacco and alcohol is actually a risk. So if you're a health worker, already you're stressed and you have all the previous things I've talked about, and then you had early access to these two substances, they also found out that you're going to be at a higher risk of becoming a drug addict or a drug dependent or a drug abuser. A genetic predisposition, that one is self-explanatory. Certain things, like we said, like someone said, the good Lord created people, but it wasn't exactly fair. He did not give everyone equal opportunity and equal protection from certain things. There are others who have diseases that kill them early, and the rest of the people are just walking around. Others are more likely to get addicted to some drugs than others. So that is also a problem that you have to be looking out for. And then previous experience with controlled substances. These are more of relapses. If you use any of these controlled substances before, then you're also at a greater risk of, as a health worker, you're also at a greater risk of developing or with carrying on or reacquiring the experience. Psychiatric conditions, coexisting psychiatric conditions have also been found to be linked to a higher risk of getting dependent on some of the substances. Family history of drug or substance use disorder. If you grew up in a home where your father or your mother was dependent on drugs or was abusing drugs, then you are also likely to do this, whether you're a health worker or not. And then there's something called solidarity. If you work in a place where your colleagues have a lot of solidarity, they never want to report their colleagues who are abusing drugs, then the habit will always continue and more people will eventually get hooked on it. So this particular attitude is also a risk factor for you becoming dependent on these substances. Now, these are some of the most useful aspects. This is one of the most useful aspects of this talk, because this talk, this talk was supposed to be one for generating awareness so that you know what is going on around you, and you need to be on the lookout for some of your colleagues who may be abusing these substances. But now, how do you know, or how do you start seeing? One of my professors said that the eye sees what it knows. So if you don't know, then even if you see it, if you don't know something, even if you see it 100 times, you will never be able to identify it. So that is why this slide is very important, and I'm going to go through it so that when you go back to your workplace, you start looking for some of these things. If you see them appearing in more often in one of your colleagues or with one of your colleagues, then you need to be suspicious and see how you can approach them and get them the help that they need. So the first one is, they are not in any particular order. Don't think that because something is at the bottom, it's the least useful sign or symptom that someone may display. These things have been arranged in an haphazard manner. They don't fall in a particular order. It's not ordinal. So one is someone who is frequently switching jobs. The person is here, then the next time you hear, oh, the guy quit this job, he went to Gulu. From Gulu, you hear the guy has crossed over to Sudan, and then he's coming back. That should be a red flag. I'm not saying everybody who does that is a substance abuser, but all I'm saying is watch that person more carefully, especially if you do not see a very tangible reason why they should actually be doing all that shifting between jobs here and there. The HR people may be interested in this. And then there's falling asleep while on the job. You are doing something and you just decide to sleep off. You are anestherizing a patient. Instead of the patient sleeping, you're also sleeping with the patient. And sometimes the patient wakes up while you're still sleeping, and the surgeons are like, what is going on? Then they're like, oh, the anesthetist is sleeping, wake him up. Or sometimes they're not sleeping on the job, but somewhere in between shifts, they're just too drowsy, they're sleepy. Sometimes they're under the influence of drugs and alcohol. The other characteristic which cuts across almost everywhere is volunteering to cover people's shifts. If you see someone who is overzealous about covering people's night duty, they are always working in the hospital overtime, they never want to go home. The guy tells you, and this is one thing that happened to our colleague, and when we looked back, we were like, this guy is always sleeping in the hospital. What is the problem? He's on the hospital couch sleeping. You have a home, you can't go there. So this guy is always volunteering to cover work in the hospital and overtime. There is always a red flag because they're trying to stay close to what they want or what they need. And that is the substances that they get from the hospital. So you need to be vigilant when you see someone exhibiting some of these features. The other thing is financial stress, family stress, and relationship stress. This has been observed and found out that people who abuse drugs, the drug-dependent people, health workers, and in the community, they always have these three things going on. It's like they never seem to get out of it. Because one way or the other is you have to finance your habits. If you drink a lot of alcohol, you'll always have to buy. People can't always keep buying it for you. So you find that you always don't have money. And yet you want what you want, but you don't have money. And if you don't have money, you're going to miss out on a lot of obligation, family obligation or relationship obligations. And then all that is going to be turned into a big giant ball of fire. And it's going to be a problem. So for people who are these, please maintain a high index of suspicion. The people who don't do their work completely, they are having, imagine you're giving an anesthetic or you are looking after a patient, you're observing patients, but then you never seem to complete your work. So you're not chatting completely. And even when they do it, you look at the papers and you see there's a lot of error in the paperwork. That kind of absent-mindedness comes from something way more powerful than just sleep or lack of sleep because of genuine reasons. Although it could happen, but if you look at this, maintain a high, have a high index of suspicion. If your colleague comes in smelling alcohol or is using lots and lots of mint, or they come to the hospital and they're like a walking, like someone poured mouthwash on them. They're trying to hide something. There's a particular scent that they're trying to hide, and that is usually some form of substance that is not, which is not legal, or they're using it in a way that is not legal. This next one is very popular. Like Dr. Rachel mentioned, one moment someone is okay, is not okay, and then the next moment they appear and they're completely composed. Everything is fine. They're no longer sweating. Their hands are no longer shaking. They look normal, as opposed to 10 minutes ago. One of my lecturers he was an alcoholic. He doesn't go, even if he goes for meetings, he has the circuits of Waraji. Thank God they were banned, but he would call them airbags. So he starts shaking, he starts getting tremors. In the middle of a meeting, he goes out to the bathroom, he sips about one or two of them, and he comes back completely composed. You will not even recognize this is the guy who was shaking and sweating 10 minutes ago. So if you see your colleagues looking very unwell, and then after a few minutes, they come back and they're looking okay, there's nothing wrong, they're more composed, then you always have to suspect that someone has gotten a fix, and for that time, they're actually good. One of the surgeons said, I used to leave, one of the surgeons confessed to leaving patients who are bleeding on the table just so that he can go get his hookup, and then he comes back and continues the surgery. All he does, he says, take over this, clip these bleeding vessels, let me come back. It doesn't, he has no regard, he had no regard for at what stage is he actually leaving the operation. That's the problem with drugs. So he just needs what he needs. So he has to get out, go use, and come back and finish his procedure. And these breaks are never, they are always there. They're endless breaks. They're always going to some secluded place like the bathroom. They're always having bathroom breaks. So this needs to be one of the things that should tell you, this person could be having a problem. The other fellow is the guy who always volunteers to give drugs to patients, especially drugs that have the propensity for abuse. You want to give patients opioids, but there's this one guy who is always offering to go and give it to patients. That should also concern you and make you more vigilant, make you suspicious. Then your colleague who is always requesting for a lot more medicine than his colleagues. Imagine everyone, let's say, uses on average maybe about a maximum of about 5 milligrams of morphine or 10. His patients are always having way more medicines than what the rest of the people generally prescribe. Now, this particular scenario is important because usually the excess one did not actually go to the patient. They're using it. And then if you look at what the patient, especially for prescription opioids, someone says, I requested for this amount of this number of micrograms of fentanyl, and I've given all this, the dose is high, but the patients are always complaining of pain. So where did these drugs go? So you need to ask yourself, so when you're working, you don't only have to look at what you're doing, but you need to be conscious of your environment and see what your patients actually are doing. So the pain scores of the patients don't usually match the amount of medicines that they claim to have prescribed. Working night shifts, these are the overtimes, the extra. These night shifts are important because this is the time when you have sort of a skeleton staff in the hospital. The administrators are at home snoring. The HR people are not around. Whoever is in the hospital is someone who generally directly looks after patients, or their auxiliary staff, like the cleaners and the lab technicians. Generally, around this time, people are not that strict. There is not a lot of people watching what you're doing. So most times, they prefer to come and work in the night. They're always in the hospital in the night. And this is not just for drug abuse. Even people who take money from patients, they're always there at awkward hours when not a lot of people who can ask questions are around. So these working nights, people who are always on chronic nights, you never find them during the day. They never want any duty which is given to them during the day. They always want to do the night one. Even if you give them a day shift, they'll find a way of switching with someone because everyone wants to work during the day. No one wants to work in the night. So they'll always be switching over. Others they can either have dilated pupils or pinpoint pupils or glassy eyes. And this will depend on what it is that they are. But you will definitely see that this patient, this particular person doesn't look okay. Then there are these ones who know who handles which drugs, like who prescribes what. Like they know if I have so-and-so has access to pethidine, this one has access to this drug. So you find that they are very friendly to such people. So they're always in their good books. They're always trying to be in good books with these people so that they can have a softer landing when they ask for these drugs. And most times they actually get it. They may give you stories, but eventually, until you actually find out they're abusing it, you will eventually give it to them and maybe regret later. Frequent bathroom breaks, I've talked about this. And then people who are commonly joking about using drugs. Yes, they start it as a joke, but it's actually a cover. They're actually using the drugs like in real life. So if someone keeps joking about using drugs, you need to look at them, watch them a lot more carefully. This is also one of the slides that I thought would be important. And I think as doctors and nurses, we have a lot of guilt. We have seen our colleagues use drugs. We have suspected them. One time, one of my former students came and says, your friend, he's always in the hospital, he's always sleeping. And then one time I found a vial of fentanyl, and I told her I'll look into it. But when the time came in and the fellow was admitted and we are obliged to report this, people were very hesitant to actually call the medical council and say, we think so-and-so is not fit to practice at this time. He needs to clean himself up and come back. And when he's clean, then they can start their work. That never happened. Instead, we tried to sort the issue at a lower level. Okay, fine, let's talk to him or her. Then we go get them into rehab, get them treated, and then get them back in. But if we look back now, we realize that, we basically wasted time, because that only helped for a while and the problem continued. So don't feel guilty. If what you should look at is, I'm basically now advising you to snitch. If you think someone is abusing substances, whether they're prescription ones or illicit ones, it's your duty. It's a duty that you hold to your patients or to their patients, to the community, to yourself, and to everybody else, to report, make sure that they get the help they need and they get better. So what should you do is, one, be vigilant. That's why I was giving you this long list of things that you can use to identify or to screen out people who may be at risk or those who are already actively using these substances. Now, with vigilance, you observe. One, first of all, maintain a high level of vigilance. Two, observe. Three, confirm. And part of the confirmation is basically confrontation. Says, just tell us if you're using these drugs or not. But the other thing that you could do is HR people or the admins can summon you and do some tests on you. They'll tell you, we're going to need your urine and A, B, C, D. They'll test them to confirm. And after that, they will report. Because one way or the other is you will get better. Yes, you may say, I'm able to do my work, but who knows when that is going to stop? You may kill somebody because you're under influence of drugs. So please, you owe it to yourself and everybody else to report anyone who you suspect is abusing drugs. That will impair their judgment or the quality of care that they deliver to their patients. Some of you may not know, but the Uganda Medical and Dental Practitioners Act of this country of 1998 actually does not allow a practitioner, and in their words, the practitioner is a medical doctor. I don't know what the nurses have and what the allied health has, but for practitioners, for medical practitioners, they are not allowed to work on patients when they're impaired. It doesn't mean you can't drink alcohol, but if you drink it to a point where you can't do what you are supposed to do or what is expected of you, that is impairment. And the people who are very prone to impairment are nurses. They say when nurses eventually start using, their rates of impairment is quite high. Some of the anesthetists, we had one in Barra who will take ages to give a spinal anesthetic. What you needed to do is he couldn't draw, let's say 15 milligrams of bupivacaine from a vial. It's impossible. If you give it to him, he'll just be doing pass pointing the entire time. Like, he can't get that needle and put it in the vial and take the amount of drug that he needs. But when he does that, then he's definitely going to succeed in giving him spinal. So you ask yourself, should I report this person? And if I report him, who is going to do his work? That's the other issue. If he gets fired, or if he gets put on leave to go to, who is going to do his work? Because generally people are very understaffed. So that is what you need to do. Like I said before, I'm not a substance abuse expert, so I'm not qualified to talk about how the treatment should go. I think that's something that can be organized another time. But in case you want to go and read up on some of the laborious literature which is out there concerning drug abuse, the whole range, these are some of the preferences that I decided that I managed to put on. There are a lot more than this, but if you need more references that you can go and look up and read for yourself, you can just drop us your email and we'll be able to send you this presentation and anything else that is available. Sorry for the small fonts for the literature. I thought it would be easier in the references, because if you need it, you can request for it and then we can send you the presentation. Thank you. I hope we can now move on to the discussion phase where we can see how to go on from here. Thank you.
All right. Thank you very much, Dr. Thank you very much, Dr. Obua. I kept hearing Mbara. I think my first question will be whether Mbara has the highest prevalence or incidence of people with abuse, because we're about to start looking at everyone from Mbara as either use of speed care or something like that.
Maybe.
Just a few questions that have come in through the chat. Before we go into those questions, how does one get help? They know someone, it's usually not us, it's usually our neighbor who has a problem. So how do we help our neighbors? As you think about the answers, Mr. Benon asked that if I sip a few beers on a weekend, but it doesn't affect my work or health, I don't know what he meant by this. Am I good? Or should I be worried? What if I eventually get addicted? That's Mr. Benon's question.
Yellow.
Okay, thank you, Benon. Like I said, doctors abuse alcohol a lot. They abuse alcohol a lot, and for the male drinkers, they're usually between medium to high-end use. Yes, it may not be able to affect your work. That's why I said earlier that doctors are generally highly functional abusers. They can drink, get really high, go do whatever it is they're supposed to do, and get back home. So that is still a problem. But what are we talking about when we're talking about misuse disorders? There are a number of drinks that you're allowed to have, and if you go beyond that, then it's going to be a problem. For males, they talk about 6, and for females, they're looking at an average of about 4. But I know some ladies who drink they're talking about 6 standard drinks. Now, how the drinks are calculated, and how much you're allowed to take will now differ from jurisdiction to jurisdiction. Not everyone has the same amount. And just because they say you should not take more than 6 drinks doesn't mean that if you take it, you're going to be impaired. It should be about self-discipline. There are some questionnaires that you can answer, and I think the doctors actually need to answer these questionnaires to see where they fall. But in case you think you already have a serious problem, there are treatment programs. I tried to reach out to the specialists who actually treat this substance abuse, especially in Butabika, and some of them are faculty members, but they were a little bit slow at getting back to me. They were supposed to give me a lot more information on the actual numbers of how many health workers they see with this substance substance abuse disorders. That would have helped to put some light and give us more perspective. I don't know if that is enough, but I think next time when we're going to have this, we're going to try and endeavor to make sure that some of these specialists, these substance abuse specialists, actually come on. I hope there are some of them in the waiting room who can actually be able to give more information on how the people who are already affected by the problem can actually get treated. Thank you.
Okay, thank you, Dr. Obua. Still under in relation to alcohol, Dr. Kwizer is wondering whether alcohol actually help.
Alcohol breaks. I'm not sure who would actually ask for alcohol breaks, except for the people who are actually alcoholics. If you're not dependent on the alcohol, I don't think you actually need the breaks. But in case you think you need an alcohol break, I think where you need to actually go is to go for treatment. I'm not a specialist in this. I have never taken an alcohol break at work, so I don't know much about this. I'm sorry.
Okay, we'll leave that for Dr. Kwizer to answer.
I'm seeing another question from Dr. Richard Bugembe.
Yes, about ephedrine abuse in Uganda.
Okay, Dr. Bugembe is wondering. Yes, Dr. Bugembe is wondering if we have some information on possible ephedrine abuse in Uganda. He's based in the South African region, and he says in the South African countries, it's hard to come by ephedrine because of abuse, because it's an abused and controlled drug. Phenylephrine and other vasopressors are the order of the day. In these countries, users change the liquid ephedrine into powder for sniffing. Okay, this is unfortunate. Yeah, so ephedrine and other decongestants are actually very prone to abuse. In Kenya, especially, these are actually over-the-counter medicines. They have some form of ephedrine in them, the cough linctors and other things that children use. But unfortunately, it's not the children who are using them anymore. They just go, school children go to the older ones. They go to pharmacies or to drug shops, and they buy these cough linctors and others alike, and just drink them, whether at school or after school hours. They just drink them. In Uganda, I've not read any literature that points toward this epidemic, but I'm sure there's nothing that we don't have in Uganda. We just have to look a little bit harder. Just like the ketamine, they try to crystallize them. They heat it up in a spoon and then crystallize it, and that is what they sniff. I think it's the same MO they're using for the ephedrine, but it's something that we need to be on the lookout for and see. Maybe the drug authority could have some information. I'm sorry, I did not get this, but I promise to find this information. It is there. But what I know, the children are using a lot. The secondary school children are using a lot. Students are using a lot, is actually ketamine. I'm not sure that they're just using it to spike their drinks, and that's it. They're not crystallizing it and sniffing it. They're just using it to spike their drinks, their sodas, and whatever it is, and then they just drink. Yes, the slides will be shared to whoever needs. Yes, Juicy, I've seen you. Thank you for attending. I'll be sharing the slides later.
One more question from Dr. Fiona, yes, about what support systems have been used elsewhere.
What support systems are being used elsewhere? So in other places, the drug problem is one of the reasons why we still have persistent drug problems, because no one wants to admit that they have a drug problem. Even when they know they have these problems, they are always hiding with it. They never want to let anyone know, and they don't want to be exposed because of stigma. Now imagine I come out and say, I'm Dr. Obua, I'm an anesthesiologist, And then I have to declare, let people know that I'm having issues with my beer, or I'm having issues with some prescription opioids. It's not something which is easy. So in those environments, what they do is, part of the support system is to help the people know that it's okay for you to ask for help when you need it. The occupational safety, because this is partly an occupational safety issue, because the mere fact that you work in a hospital, you are exposed to certain things. It's just the way you expose to certain diseases that other people are generally in the community are not exposed to, just from the mere fact that you work in a hospital. So it is, the drug problem is seen from an occupational aspect, in that the hospital usually has therapists who can talk to people either because of stress they're having at work or the stress they have at home that may move them. So what they do is they routinely screen the health workers for risk factors, so that they can watch them and see when to advise them to go for help. But the most important thing is to let them know it's okay to ask for help as long as you get better. And the good news is, health workers, unlike the rest of the community, when health workers are identified early and they are actually treated, they have been found to respond to treatment better than anybody else. So if you're committed and you go for your treatment, they're usually able to get back to work and get their lives back to normal if they are professionally treated. So if you're using drugs, be open to it, let someone know, get help, and you may just be able to, there's a very good chance you're going to get your life back on track. So those are some of the support systems they have. But even within the hospitals and the communities, they have these support groups that help people who have challenges with certain things, whether it is addiction to drugs or dependence on drugs and other social problems. They have AAs, they have groups for cocaine addicts, they have groups for ex-cons. So those support groups are not just at the workplace, but also in the community. Here, I don't think we have as much.
All right. Thank you very much, Dr. Obua, for that very elaborate response. I don't see any other questions in the chat or any other questions being asked. Thank you very much, everyone, for attending. We'll just request you, Dr. Obua, to give us your parting shots before we can close this.
Thank you. What I would want to say at this time is that the drug problem is real. It is bad. It's affecting people's lives. It's affecting your colleagues. It's going to affect your patients, and it's going to affect you as an individual. So you need to be vigilant. Protect your colleagues. If some of them will never accept the help. So, but you still have to forcefully find a way of helping them. You have a lot of risk. Avoid stress. Stress is one of the biggest problems you have. And please try not to experiment with any drug that I was telling someone I've been an anesthesiologist for a very long time. And I, at some point, used about 100 micrograms of fentanyl when I had one of those crazy dental removing one of those bad molars. But that's the last I had of it. That was maybe about 13 years ago. But I've never had it. I don't have any curiosity. If I want to drink something, I'll probably go drink my beer. I even fear the other distilled ones. So try to know the risk factors that you have, know that you're at risk, and try to guard yourself against it, guard your colleagues. In case you have problems, please come approach anyone that you're comfortable with, let them help you. Someone was asking, has the Association of Anesthesiologists come up with a program to help with such issues? That was about 2 weeks ago. I told them no, but now that they have mentioned it and this has come up, I think it's something that we need to seriously look into, engage the Ministry of Health and other stakeholders to make sure that the healthcare worker is actually properly taken care of, because it's because of the nature of their job and other problems that they have as individuals that will make them less useful when they get hooked up on these substances. But please be vigilant. Don't feel guilty about reporting anybody, because in the end, you're helping them. I think that is what I think that is the most important information that I can get out there. Thank you.
Thank you very much, Dr. Obua. No further questions. I guess we'll act on.
Someone is asking, is NPA a drug? Yes, it is. It is. It's a substance which is very frequently abused. It is.
Okay. I don't see any other questions. We'll call this webinar to an end.
Okay, thank you everyone for coming.
Thank you everyone for
thank you,
sparing your
Troika,
time.
for sponsoring this. Thank you for attending. We hope to get you people back here the next time we're discussing something that affects our lives. Thank you again.
All right, thank you.
Color the picture. Color